What if I told you that skipping your dentist appointment could actually, wait for it, trigger premature labor?
Yeah, it sounds completely made up, but it is very real.
Right. Or, the exact date you're supposed to give birth is calculated by this like 200-year-old math formula that is almost always wrong.
Mathematically predicted and almost universally inaccurate.
Exactly. So welcome back to the Deep Dive Learner. Today, we are basically tearing down everything you thought you knew about
Oh,
pregnancy.
really are.
Because usually we picture having a baby as this purely biological event, right? You get two pink lines on a stick, you have a quick doctor's visit, and boom, you're on a 9-month countdown.
Great. A simple biological timer.
But if you actually look at the mechanics behind it, having a baby is this massive psychological, social, and logistical earthquake.
Oh, absolutely. The ground beneath a family completely changes shape. I mean, they literally have to learn how to stand on it all over again.
And to figure out how they do that, we are pulling insights today from the Comprehensive Guide to Prenatal Nursing Care and Family Adaptation by Diana L. McCarty.
It's a fantastic text. And for this deep dive, we are skipping all the cliche baby advice. We're getting right into the clinical blueprints.
Yeah, no tips on painting the nursery today.
Exactly. Because the actual clinical goal of prenatal care goes way beyond just, checking weight and taking blood pressure. It's about holistically preparing an entire family ecosystem for what the medical world calls a maturational milestone.
A maturational milestone. I love that phrase.
Okay.
And learner, if you've ever had a kid or even just been close to someone who has, the chaos begins the exact second you suspect something is happening.
Oh, yeah. The rumor mill starts in your own head.
Right. Because before a family can adapt to anything, they actually have to confirm the pregnancy and figure out the timeline.
Which is a whole process in itself.
It really is. When you look at the clinical blueprints, medical professionals actually break down the signs of pregnancy into 3 distinct tiers.
Right. The presumptive, probable, and positive signs.
Yeah, and I like to think of this as like building a legal case. So the presumptive signs, those are your circumstantial evidence.
The subjective things the patient feels.
Exactly. Things like fatigue, nausea, or maybe a missed period. And sure, you might be pregnant, but you could also just have a real bad stomach bug or be, incredibly stressed out at work.
Right. It's a clue, but it absolutely wouldn't hold up in court.
Nope. So then you move up a tier to the probable signs.
And these are the objective changes, things that a medical examiner can actually see, like changes in the cervix or the big one, a positive over-the-counter pregnancy test.
Which, I mean, let's be honest, feels like finding a smoking gun.
Oh, completely.
Most people see those 2 pink lines and consider the case closed, like done deal.
They do, but clinically, a positive test is still only probable.
Wait, really?
Yeah, because those home tests are designed to detect a very specific hormone, HCG. But pregnancy isn't the only thing that produces HCG.
Oh, I didn't know that.
Yeah, certain pelvic infections or even specific types of tumors can actually cause false positive results. So relying solely on a chemical marker leaves a margin of error.
So you need that final tier for the absolute undeniable proof.
Exactly, the positive signs.
That is catching the suspect on video.
Right, it's undeniable proof where there is literally no alternative medical explanation.
So we're talking about what, a doctor physically hearing the fetal heart tones with a Doppler?
Yes, or actively seeing the fetus moving on an ultrasound.
Wow. Okay, so once you have that undeniable proof, the immediate next step is calculating the deadline, right?
Yeah, this is where dating the pregnancy comes in. And it is arguably the most critical piece of baseline data a medical team can gather.
And the standard tool for this is that 200-year-old math equation I mentioned, the Nagel rule.
The Nagel rule, yes,
Yeah.
which calculates the EDB, the estimated date of birth.
Right. And I looked at the math for this, and it sounds incredibly precise. I mean, you take the first day of the last menstrual period, you subtract 3 months, add 7 days, and then add 1 year.
Yep, that's the formula.
And boom, you get this specific date circled on the calendar. But here is the wild part, learner. Only about 5% of women actually give birth spontaneously on their exact calculated EDB.
Yeah, 5%. Because the human body doesn't run on a precise train schedule, Most births happen anywhere in a window of like 7 days before to 7 days after.
Which made me wonder, initially anyway, why does the medical system care so much about nailing down a date if it's that imprecise?
It's a good question.
But I realized, looking at McCarty's work, that the date isn't about predicting the baby's birthday for the sake of, like, planning a party.
No, not at all.
It's the anchor for every single clinical decision for the next 9 months.
Exactly. Think about it. If a pregnant woman's blood pressure spikes dangerously, the medical team has to make a call. Do they deliver the baby immediately or try to wait it out?
And that life or death decision depends entirely on exactly how many weeks and days along she is.
Precisely. Accurate dating dictates when to screen for genetic markers, how to evaluate if the fetus is growing properly. The calendar dictates the protocol.
Wow. Okay, so once that physical reality is locked in on the calendar, the biological machinery is in motion. But the mind has to furiously catch up.
Oh, the transition from the biological to the psychological adaptation is intense.
It really is. And this part of the clinical research completely blew my mind because there's this deeply ingrained cultural expectation that a wanted pregnancy should equal, pure, unadulterated joy.
Right, the glowing mother-to-be.
Exactly. But the clinical reality actually involves profound maternal ambivalence.
Yes.
Even if someone has wanted a baby their entire life,
Right.
it is incredibly common and completely normal to feel hostile toward the pregnancy.
It really is. A woman might be thrilled about the baby, but simultaneously feel this deep regret that her life, her independence, and her body as she knows it are fundamentally ending.
Which makes total sense when you say it out loud.
Right. It's a collision of profound hormonal shifts and the sudden, crushing realization of lifelong responsibility. I mean, a partner making a chance remark about her weight gain or seeing a coworker get a promotion.
Oh, I bet that hurts.
It can trigger intense feelings of resentment, and medical professionals are trained to actively validate that ambivalence so women don't just drown in unwarranted guilt.
It's a massive cognitive restructuring. And the source text actually brings up nursing theorist Reva Rubin, who mapped out this psychological adaptation into 3 phases.
Rubin's phases are fascinating.
Yeah. So in phase 1, the focus is entirely on the self. The woman says, I am pregnant. And the fetus is viewed merely as like an extension of her own body.
Right. But then around the 5th month, a profound shift occurs.
The quickening, right?
Exactly. The moment she first feels the baby move, the thought shifts to phase 2, which is, I am going to have a baby.
So the movement provides undeniable proof of a separate entity.
Yes, she starts psychologically separating the fetus from herself.
And finally, you hit phase 3. I am going to be a mother. She begins defining the child's traits, maybe imagining their personality based on how aggressively they kick.
Right, like, oh, we've got a soccer player in here.
Exactly. And realistically preparing for the birth itself, but, and this is crucial, it's not just the person carrying the baby who goes through this mental metamorphosis.
No, not at all. Non-pregnant partners have their own distinct psychological journey.
Right. The clinical framework outlines 3 phases of partner adaptation: the announcement phase, the moratorium phase, and the focusing phase.
And that moratorium phase is particularly fascinating.
It sounds like a psychological pause button.
That's a great way to put it, because while the pregnant woman's body is rapidly changing every single day, the non-pregnant partner often processes the reality by turning completely inward.
Just totally shutting down.
Not shutting down necessarily. It's a period of intense introspection. They aren't ignoring the pregnancy. They're performing an existential audit.
Wow, an existential audit.
Yeah, they engage in deep philosophical reflection. They intensely reevaluate their own relationship with their parents, their career trajectory, and their overall philosophy of life.
So they are trying to figure out what kind of parent they're going to be by, like, forensically examining the parenting they received.
Exactly.
Learner, think about how this internal psychological shift ripples out. I mean, it doesn't happen in a vacuum. It forces the entire family structure, the whole ecosystem, to reorganize itself.
The ecosystem is a perfect word for it. Take siblings, for example.
Oh, siblings. Their reactions are entirely dependent on their developmental age, right?
Completely. A 1-year-old is largely oblivious to the impending earthquake. They just don't get it.
But a 2-year-old.
A 2-year-old, however, thrives entirely on sameness and routine. They notice their mother's physical appearance changing and that subtle shift in household attention.
So they get anxious.
Very. This anxiety over change often leads to clinging behavior or major regressions, like suddenly losing their toilet training progress.
Oh, man, that sounds stressful. But then you get to the 3 to 4-year-olds, and they are just fascinated by the mechanics of it. They just want to hear the heartbeat on the Doppler over and over again.
Right, it's magical to them. And then school-age kids treat it almost like a clinical science project.
How does it get out?
Exactly. They want the anatomy lesson, but the teenagers...
Oh, this part is hilarious.
Really is.
For a teenager, the biggest issue with a pregnancy is often the sheer, mortifying embarrassment of realizing their parents are sexually active.
It's the worst thing that could possibly happen to them. It forces a teenager to confront their parents' sexuality at the exact moment they're trying to awkwardly navigate and establish their own.
It just shatters their perception of their parents.
It really does. And, we can't forget the grandparents in this ecosystem either.
Right, because a new baby usually provides a beautiful link to the past, a continuation of the family line. But some expecting grandparents actually react negatively.
Yeah, and it's because it's a glaring reminder of their own mortality. A new generation coming in is undeniable physical evidence of their own aging.
That is a lot of complex family dynamics to manage.
Mm.
And the medical system has to navigate all of this within a much broader cultural context, too.
They do, and trust is the absolute prerequisite for care here.
Right, which brings us to culturally sensitive care. And this is where it stops being just a buzzword and becomes a matter of strict medical safety.
Exactly. Because Western medicine strongly pushes for early, frequent prenatal visits with extensive physical examinations. But in many cultures, exposing body parts, especially to a male provider, is a severe violation of modesty.
And if a clinic operates rigidly and doesn't accommodate those cultural boundaries, what happens? That family will simply avoid the healthcare system altogether.
They'll just disappear from the schedule. And the clinical guidelines also dive deep into the adaptation for LGBTQIA couples.
Yeah, learner, think about walking into a clinic and every intake form, every informational poster, and every question from the receptionist only assumes a traditional heterosexual dynamic.
The feelings of isolation or invisibility for non-birthing partners and same-sex couples, or for transgender individuals navigating pregnancy, can be absolutely overwhelming.
I can imagine.
When healthcare professionals use heteronormative language, they unintentionally sideline a crucial part of that family's ecosystem.
And just like with cultural modesty, alienation leads to avoiding care. If they don't trust the provider, they won't show up for the blood pressure checks or the vital screenings.
People need to feel seen and respected for their healthcare outcomes to improve. That establishes the foundation for the medical team to introduce the prenatal toolkit.
The toolkit. Because the family is undergoing such massive physical and social stress, the medical system steps in to manage the risk through very specific protocols.
Right. And one of the most fascinating alternatives to the traditional rushed, one-on-one doctor visit is group prenatal care.
Often called the centering pregnancy model.
Yes. Instead of sitting in a waiting room alone, women with similar due dates actually receive their care together in a structured group setting.
So they learn from each other's questions and build a community of mutual support.
Exactly.
And the clinical data actually backs up that community feeling. Group care is statistically linked to lower preterm birth rates and significantly better breastfeeding initiation.
It makes a real difference. But regardless of whether a patient chooses group or individual care, there are standard physical measurements that must happen.
Right, like measuring fundal height.
Yes. Providers literally take a tape measure to the belly to estimate the weeks of gestation and ensure the fetus is growing properly.
But during these exams, there is a critical physical warning that providers drill into their patients. Pregnant women in their second and third trimesters should never lie flat on their backs.
Never. This involves a vital piece of physiology called supine hypotension.
Okay, break that down for us.
Sure. So the gravid uterus, the womb carrying the growing baby, becomes incredibly heavy. If a woman lies flat on her back, the sheer weight of that uterus completely compresses the ascending vena cava.
Right, the main vein. For anyone rusty on anatomy, the vena cava is the major vein returning blood from the lower body back to the heart.
Yes.
So lying on your back during late pregnancy is essentially like dropping a heavy water balloon right on top of a garden hose. You are cutting off the water pressure to the rest of the house.
That is a perfect analogy. Cardiac output plummets. The woman will almost immediately experience dizziness, pallor, and a severe drop in blood pressure.
And more importantly, it drastically reduces the vital blood flow to the placenta and the fetus.
Exactly. So providers mitigate this by simply placing a wedge under the woman's hip or advising her to lie on her side, which just rolls the weight off that major blood vessel.
The mechanics of the body during this time are just so interconnected. Which actually brings me back to the fact I mentioned at the very beginning of this deep dive.
Oh, the dentist.
The dentist. The clinical research goes into these surprising self-management facts, and I had a major realization regarding oral health.
It's a surprising connection.
Yeah. Brushing your teeth and seeing a dentist during pregnancy isn't just about preventing cavities because you're eating more sugar. It could literally prevent a premature birth.
The mechanism connecting the mouth to the uterus is very real.
How does that even work?
Well, during pregnancy, profound hormonal changes naturally cause an increased incidence of gingivitis, which is inflammation of the gums.
Okay.
If that inflammation is ignored and progresses to periodontal disease, it creates a chronic systemic bacterial infection in the body.
And the body's immune system detects that infection in the gums and responds by releasing inflammatory markers into the bloodstream.
Right. And here is the kicker. Those exact same inflammatory markers are what the body uses to signal that it's time for labor.
Wow. So the gum infection essentially tricks the body.
Yes. It can prematurely trigger uterine contractions and cervical changes, leading directly to preterm birth or a low birth weight baby.
Your gums can literally trigger labor. That is wild.
It is. Another major preventative tool in the toolkit, though, is vaccines.
Right. And the clinical guidelines are very strict here. Pregnant women cannot receive live virus vaccines, like the MMR for measles, mumps, and rubella.
Correct. Live viruses pose a potential risk of crossing the placenta and harming the developing fetus.
However, inactive vaccines are highly recommended, specifically the flu shot, the COVID-19 vaccine, and the Tdap vaccine.
The Tdap, which protects against tetanus, diphtheria, and pertussis, better known as whooping cough.
Now, I originally thought the Tdap shot was just to keep the mother from getting sick.
Yeah.
But I realized reading this that it's actually about hacking the placenta to pass temporary armor to the baby.
Hacking the placenta, I like that. Yes, infants are highly vulnerable to whooping cough, but they are too young to be vaccinated themselves when they are born.
So it comes down to passive immunity.
Exactly. When a mother receives the Tdap vaccine between 27 and 36 weeks of gestation, her immune system ramps up and creates specific antibodies.
And those maternal antibodies actively cross the placenta.
Yeah. Equipping the infant with short-lived passive immunity the very moment they enter the world.
But here is the catch. Those maternal antibodies drop significantly within a year. The temporary shield fades.
It does.
So even if a mother had the Tdap shot for her first child, she has to get it again for her second and her third. She has to generate a fresh batch of antibodies during every single pregnancy to ensure that specific infant gets the protection.
Right. Every single measurement, every vaccine, and every behavioral adjustment is calculated risk mitigation.
It even extends to everyday actions like wearing a seatbelt.
Oh, absolutely. A pregnant woman cannot just throw a seatbelt across her stomach.
No, the lap belt must be positioned low across the rigid pelvic bones, completely under the bump, with the shoulder harness resting above the uterus.
The ultimate goal is to safely navigate the mother and fetus toward the finish line.
Which is the birth. All of this careful measurement, the psychological preparation, the family reorganization, it all culminates in a single monumental event.
And families have to make complex decisions about where and how this happens.
Yeah, the clinical sources outline three main settings. First, you have the standard hospital setting. Modern hospitals often use LDRP rooms, labor, delivery, recovery, and postpartum.
You stay in one home-like room for the entire process, but all the emergency surgical equipment is cleverly hidden behind the woodwork, just in case.
Right. Second are freestanding birth centers.
These are typically staffed by certified nurse midwives and cater strictly to low-risk pregnancies. They offer a highly personalized, home-like environment, often resulting in early discharge.
But they still maintain strict protocols for rapid hospital transfer if complications suddenly arise.
Right. Exactly. Safety is still paramount.
And third, home births. The data actually shows that home births have increased, especially since the COVID-19 pandemic when people were desperate to avoid hospital environments.
They have. And the clinical texts approach this very impartially, heavily citing the American College of Obstetricians and Gynecologists, or ACOG.
What's their stance?
Well, ACOG fully acknowledges that women have the fundamental right to choose low-intervention environments. However, their clinical data strongly supports hospitals or accredited birth centers as the safest settings.
Because of the risks.
Yes. Statistically, planned home birth carries an increased risk of perinatal death and serious neurologic dysfunction in the infant.
Wow.
Furthermore, home birth is absolutely contraindicated, meaning medical professionals strongly advise it should never be attempted if the woman is carrying multiples, like twins, or if she has had a prior cesarean birth due to the risk of uterine rupture.
So it all comes down to evaluating the individual risk profile.
Precisely.
But beyond the location, the environment in the delivery room is heavily shaped by who is actually in there supporting the family. And the role of the doula is absolutely fascinating to me.
Doulas are incredible.
Yeah. A doula is essentially your highly trained personal tour guide through a very intense, terrifying foreign country while your nurse and doctor are the pilots strictly focused on flying the plane safely.
That is exactly it. A doula does not perform any clinical tasks whatsoever.
Right, they don't check blood pressure, they don't monitor fetal heart rates, and they definitely do not deliver the baby.
No, their sole purpose is providing continuous physical, emotional, and informational support to the laboring woman and her partner.
And the statistics on having that tour guide are incredible. Having continuous support from a doula statistically lowers the need for pain medication, decreases the use of epidurals, and actually reduces the risk of needing a cesarean birth.
It really proves how deeply a woman's psychological state impacts the physiological process of labor.
Mind and body connection.
Totally. If you feel emotionally supported and less afraid, your muscles hold less tension and your body progresses more efficiently.
And to help manage those psychological expectations, families are highly encouraged to create a birth plan.
Though the clinical advice is to view a birth plan as a tentative, best-case scenario preference list, rather than a rigid legal contract.
Because labor is inherently unpredictable.
Very dynamic. The real value of a birth plan isn't the piece of paper itself. It is the vital communication it forces beforehand.
Between the partners and between the family and their healthcare providers.
It gets everyone on the exact same page before the earthquake hits.
Learner, what we've uncovered today is that prenatal care is infinitely more complex than ultrasound pictures and, remembering to take your daily vitamins.
It's a profound restructuring of human life.
It really is. It completely changes a woman's physical body. It forces a partner to forensically rewrite their own identity, and it forces an entire family dynamic to shift just to make room for a new person.
As we wrap up, I want to leave you with a final thought to mull over, learner, something that builds on the clinical data we've discussed today.
Let's hear it.
The source texts mention a recent massive shift in modern medicine toward virtual learning and telecommunication. Using apps, remote monitoring, and video calls to reduce in-person clinic visits.
Right, telemedicine is everywhere now.
It is. But if we think about the profoundly physical, hands-on rituals of prenatal care, a provider physically placing their hands on a woman's belly to measure the fundal height, or the entire family gathering in a small room to hear the rhythmic swoosh of the heartbeat on a Doppler.
Yeah.
If those deeply intimate rituals become increasingly outsourced to remote technology, how might that fundamentally alter the psychological attachment and the cognitive restructuring that we now know is so vital to becoming a parent?
Man, that is a great question. Because an earthquake isn't something you can just watch on a screen. You have to feel the ground move under your feet to truly understand it.
Absolutely.
Thank you for joining us on this deep dive into the hidden complexities of prenatal adaptation. Keep asking questions, learner, and keep learning.